Hello everyone, we are back with another session with Hirad EP. As usual, please subscribe and like if you find these videos helpful. We're going to continue to review the Afib guidelines. This is a part 5, and we're going to talk about how to screen before and how to follow up patients that are already on antiarrhythmic agents. So as we talked before, this is atrial fibrillation guidelines that published in 2023. Let's talk about part 5 of it. A lot of interesting stuff. Okay, we're going to start with amiodarone, medication with a lot of side effects. As its name shows, amiodarone has a lot of iodine, up to 40% is iodine. Because of that, it can induce a lot of thyroid dysfunction, hypo and hyperthyroidism. Hypothyroidism is more common. Up to 20-25% of the folks that get amiodarone might develop hypothyroidism. Usually happens earlier, within the 3-6 months, and on average 180 days. Hyperthyroidism also can happen, but is more rare, and usually happens later on with more accumulation of amio. There's some data about average of 720 days, so it's a couple years later you can get hyperthyroidism. Nevertheless, hypo and hyper, both of them can happen early on after initiation of amiodarone or later on as well. So for that reason, we need to do a baseline testing. So you need to check the TSH, and if TSH is abnormal, then you check T4 and T3 and make sure that you catch the hypo or hyperthyroidism early on. And then on the first follow-up, you need to do another TSH check, 3 to 6 months. And after that, every 6 months is recommended to repeatedly check TSH twice a year to make sure the TSH does not get messed up. As you see, up to 24% is 1 out of 4 patients can get hypothyroidism. So it's important to monitor. The second issue that we have with amiodarone is the liver toxicity. For that reason, we check AST, ALT at the baseline, and the same fashion 3 to 6 months at the first time, and afterwards every 6 months need to be checked the liver function. Then we get the QT prolongation and the torsade that can happen rarely in amiodarone, 0.7%. For that reason, we check EKG at the baseline and then check annually to make sure the QT is not super prolonged. Although there is some level of QT prolongation we see with amiodarone, because that's basically the effect. Effect of the amiodarone has some prolongation of QT, and there are some data that if you prolong your QT, you might get a better outcome from amiodarone. Now we get to the most important, in my opinion, side effects that happens in 1 to 2% of the time. That is interstitial lung disease. So this guidelines now recommended to get a chest X-ray at the baseline testing. And then later on, if the patient develops any sign of the lung issues, shortness of breath, if you think of interstitial lung disease cooking, then you should repeat the chest X-ray. And if there's any suspicion a chest X-ray is not good enough, or you wanted to get a better understanding of the lung issues, if the chest X-ray is not enough in that sense, then you can do a CAT scan. So the CT of the chest is not recommended at the baseline. Another thing to remember is the PFD is not recommended as a tool to use for follow-up or baseline, since it's not sensitive and a lot of issues in interpretation and a lot of overlap with other disease. So basically chest X-ray at the baseline, and whenever the patient gets symptomatic, repeat X-ray. Now we get to the other 3 important things that can happen. One is corneal deposition. There's nothing recommended at the baseline, but you need to remember if the patient starts to have visual issues, so it means, I can't see well anymore. That can be early signs of optic neuropathy. And amio also can cause a lot of neuropathy. So if the patient start to have peripheral neuropathy, optic neuropathy, then needs to have a physical examination, as well as do physical examination annually to make sure you're not missing neuropathy. And if something's brewing, you need to stop amiodarone. Another thing that you can see with amiodarone, especially higher dose, is a blue-gray skin discoloration and photosensitivity. There's no derm exam at the baseline is recommended. Again, annual examination is necessary, and also you need to tell the patient, especially if you are in an area that sun exposure is significant, give a heads up to the patient that you might get photosensitivity. And if it's severe enough, of course, you need to change your strategy, stop the medication, and so forth, and so on. So basically, these are important things that you need to remember for amiodarone. T3, T4 measurements is only needed if the TSH is abnormal, but you need to check TSH every 3 to 6 months. And every 6 months when you check AST, ALT, and TFD, also make sure that you are alert for lung disease type of symptoms, including cough and shortness of breath. All right, let's go to another medication, the list of medication. Okay, so we have another nice table here, and we're going to talk about 3 medications here: dofetilide, orticasin, dronedarone, and ibutilide. For dofetilide, as we discussed on previous recordings, we admit the patient for 3 days, and the patient needs to check their EKG after each consumption of the pills. So after initiation, we also make sure the potassium and magnesium are in a good shape and the GFR is appropriate shape. We discussed that in the previous video, and if you want to know the details, please go and take a look on that. After that, so initial 3 days, then every 3 to 6 months, you need to check all these important things. 12-lead EKG, make sure the QT is still good, potassium, magnesium, and the GFR. So at least 6 months, you need to check these electrolytes as well as the GFR and make sure everything's okay. And if the patient is taking something concerning, like an increased QT interval, then you need to increase the interval, see the patient more frequently, and make sure the EKG and everything is in good shape. Dronedarone has rare cases of liver injury, usually in the first 4 to 6 months. Because of that, you need to check AST, ALT at the baseline and then within the first 6 months. There's no need to continue checking the ALT and AST. As I said, this is a rare case and happens usually at the onset, the first few months that we start Maltag or dronedarone. 12-lead EKG is important because dronedarone still can prolong QT. You don't want it to see the QT that is super prolonged and start dronedarone with that. And then we get to the ibutilide. So of course, ibutilide is IV infusion. We don't give it to the patients outside. And then we check potassium, magnesium, and sometimes we give a magnesium infusion before that. We talk about it in the previous recording. Now, the important thing is it is recommended to keep the patient for 4 hours, and that is the time that usually we see the torsade de pointes is up to 8% of the time, 2 to 7% is the range. Up to 7 to 8% of the time you can see torsade in ibutilide. So ibutilide have the higher chance of torsade, 2 to 7%, and is only short term because the patient is not going to go home with it. It's only IV infusion. Dofetilide has about 3% range. Sotalol has also kind of same 2 to 3% incidence of torsade de pointes, and the lowest among these is 0.7% with amiodarone that we just mentioned that. Okay, let's talk about procainamide and sotalol as well. Procainamide we use as IV infusion these days. It's important to look at the 12-lead EKG and the blood pressure. So procainamide causes hypotension up to 12% of the patients. So you can give it slowly and make sure you check the blood pressure, monitor it, and if the blood pressure is dropping crazy, you need to slow down or stop the infusion. And also look at the QRS as well as QTC. Since the class 1A can prolong QRS as well as QTC. So these are important things that you need to monitor when infusing procainamide to this patient. Most of the time, patients get procainamide in very controlled settings, CCU, ICU, MICU, or in the EP labs. So basically, these are the things that we always look into. Sotalol, same as dofetilide. We admit for 3-day hospitalization. We check potassium, magnesium, and the GFR, 12-lead EKG. And the same thing that we recommend for dofetilide, we should do for sotalol. It means every 3 to 6 months, you need to check the potassium and magnesium and GFR and check EKG. Make sure the QTC is okay, kidneys is okay, as well as the important electrolytes that can play a role in prolongation of QT and repolarization. If you're giving the patient a medication that can prolong QT, this means that you need to see the patient frequently or monitor the patient frequently and make sure nothing goes crazy. All right. So there were a few medications that it wasn't discussed, like flecainide and propafenone in the current guidelines. In this section, that I usually do a stress test at the baseline, especially if I have high suspicion, older patients with some risk of coronary artery disease. So we do a stress test to make sure the patient is not prone to ischemia when we start in flecainide and propafenone. And then I usually do every 1 or 2 years to make sure that there's no new development. The other aspects of treatment of rhythm treatment for atrial fibrillation is upstream therapy or prevention of atrial fibrillation. Means how we can prevent incidence of atrial fibrillation. I'm currently doing some sort of research on this to figure out who is prone, and then based on that to identify how we can prevent that. But so far there are a lot of studies, with some data but not solid data about different aspects of prevention of atrial fibrillation. One of the things is targeting inflammation. There are some data that steroid can decrease recurrence of atrial fibrillation, but of course we can't give steroid long term because it causes a lot of other issues. There are questionable data about statins, especially post-op atrial fibrillation, that is not replicated in larger study. The vitamin C also shows in some study that might prevent post-op atrial fibrillation. ACE and ARB, which initially in a smaller study showed some, promising data, especially controlling blood pressure, you think that you should prevent atrial fibrillation, but failed to reduce atrial fibrillation burden with more data that coming. And then mineralocorticoid reducers, spironolactone type of family, they might reduce new onset atrial fibrillation patient with systolic dysfunction. And more exciting data is coming from SGLT2 medications that it might decrease onset of new atrial fibrillation in patient with diabetic. And lastly, that I want to talk before I say goodbye is omega-3 that actually showed an increase of atrial fibrillation. So all the data about omega-3 decreasing stuff is good for arrhythmia. It shows that it's not consistent. So I don't recommend omega-3 for arrhythmia management anymore. It still might be good for decreasing your triglyceride and management of lipid issues. Okay, so guys, thank you again. Don't forget to give me your feedbacks to make these videos better and better. So we'll talk about the catheter ablation hopefully next week, and see you then. Take care. Have a good day. Bye-bye.